In the previous talk we spoke about Avengers. So for the present talk we would be talking about the Bollywood villains, because NTM is majorly a concern with us here. So this is the villains of the yesteryears. So the minute we would, maybe 20 years back, when we would start off seeing a patient with multiple lymph nodes or cough or cavity, we would always talk or think in terms about tuberculosis. So similarly in the Bollywood movies of the year, when we would have these guys are coming into the frame, we obviously knew that we are talking in terms about the villain of the story coming in. These are the present new age villains, where you have a shade of grey. You're not even certain whether they are proper villains or whether they are just a bystander. So similarly, we would need to look at the mycobacterial disease. So if you are looking at a TB versus an NTM, what is important to understand is that one could misdiagnose these cases as being more likely to be because of TB than NTM. You have a low sense of recognition in terms of the symptomatology, and finally we have limited resources to really go ahead with the diagnosis. And the treatment is vastly different. So it's important to really know which of the two are we dealing with. My roadmap of the talk is going to be a couple of cases followed by the usual lecture kind of a thing about the NTM. So the first case is of a 57-year-old lady who was coming from the village in Jalgaon. She was diagnosed as with an insulinoma, operated in the year July 2021. No episodes of hypoglycemia since September of 2021. Her major concerns were that of a weight loss since a period of 6 months. She weighed only about 37 kgs when I saw her. A low-grade fever on and off since October of 2021, cough with breathlessness and a reduced appetite. This was the X-ray which was done by the endocrinologist who has been treating her, and after seeing this particular X-ray, she was referred to me. So it showed the presence of a inhomogeneous haziness in the right lower zone. So a CT was also done. She came in with the CT findings as well. So there was a bronchiectatic changes with some air trapping. There was a bronchiolar thickening with peribronchovascular nodules in bilateral lung parenchyma, and they said it was more likely to be COX. So we went ahead and did some basic investigations for her, of which the procalcitonin was a little on the higher side, CREA was okay, CRPs were just at the border, our cutoff for the lab is 10, the LFTs were abnormal, and the CT findings we already spoke about. So we went ahead and did the sputum testing for her along with the gram stain, GNX and the culture. The AFB, after the first two sets, the second set showed a positive AFB, so we repeated the AFB again, which again showed it to be positive, but the GNX came in as negative. So the final culture report, which came in around the 2nd of this particular month, showed presence of mods, and we went ahead for the speciation, and we got the species as Mycobacterium intracellular, which is basically your avium complex. One of the avium complex. So presently this patient is on clarithromycin, rifampicin, ethambutol and fluoroquinolones. The sensitivity of whatever is there is awaited. We've just sent the sensitivity testing recently. The patient is apparently doing well. It's just about 7-8 days of therapy right now. I really don't have the pictures to really show you right now, but because the patient is not here in Mumbai, but these are very typical findings that you see on your CT, which looks more or less like COX. Second is a 35-year-old lady, a resident of Amravati, presented with a history of low-grade intermittent fever. She had undergone a laparoscopic procedure in view of her infertility 4 years back. And since then, she had ooze from those sides. Over a period of time, there were fresh areas in the abdomen when she started having multiple discharge from, and she was treated with multiple antibiotics before she came into us. These were the initial lesions on the abdomen. Most of these lesions, some of them seem to have healed, were probably sinuses to begin with. We picked it up as being Mycobacterium abscessus, and she was put on clarithromycin, amikacin, linezolid and moxifloxacin as per the sensitivity. The initial 2 months we gave her injectable, and as she kind of started doing well, she went on to oral medication. The way we went ahead and tracked her progress was doing every 3 monthly an MRI of the abdomen to look at whether there is any evidence of sinuses. And if once we saw the fibrosis has healed down completely, that's when when the fibrosis has set in completely, that's when we stop the therapy. This is towards the end of therapy. She is 1.5 years from the time that she's been treated and doing well, no recurrences. This is a 60-year-old male, non-comorbid, operated for an inguinal hernia, treated with multiple antibiotics because post-surgery developed pain and tenderness at the site of the surgery. Presented to us 6 months later with a small pustule at the site of the surgery with a history of drop in weight and low-grade fever. His MRI suggested typically that there were blind ending sinus tracts, and the culture showed presence of an NTM, and again this was an abscessus, and these were sensitivity, so he was sensitive only to amikacin, clarithromycin and linezolid, which is with what he was treated with. 4 months into treatment, he is completely good, doing well. That's all that we have continued the medications for. He's on follow-up. Completely healed, no evidence of infection. The last is a recent case, again a 63-year-old male, diabetic hypertensive, again underwent surgery for bilateral inguinal hernia. The wound never healed, continued to have pain and a bit of oozing from the operative side. Later on developed severe pain in the scrotal area followed by a small opening with a discharge, so he developed a sinus in that area. Came to us for an opinion, we got off the mesh, appropriate cultures were sent, and I'm not sure whether it's very visible, but 2 weeks later again we showed presence of mods. We are still awaiting the speciation for the same, but we have started the patient on treatment. So what is a MOT? A MOT and an NTM or an environmental mycobacteria or an atypical mycobacteria. These are from the mycobacterial family, which are other than TB and leprae. The references that I've taken for the talk is from ATS, IDSA, ERS, ESC, MIT, and the couple of papers that we have had from India. These are environmental organisms. They're found in soil, dust, water, and especially the natural water sources like your lakes, rivers, and streams. One of the major concerns from us is the plumbing that we look at, because these organisms are very adherent. So they stick around in the plumbing facility, and that's where we end up having a high incidence of NTM within the community. The isolation rates, these are the prevalence rates in Indian scenario as of 2020. So the rates has increased from 0.9 to about 1.6%. It may be because of a better way to really differentiate and pick up these particular organisms as against what it used to be there earlier. Prevalence of an NTM pulmonary disease among the presumptive TB patients in India is about 1.1%. The most common is obviously MAC, Mycobacterium avium complex, followed by the Chilone, Fortitium, Aspersus, and Chilone are in fact the most common organisms in extrapulmonary. MAC is more with pulmonary. The site of infection could be lungs, skin, soft tissue, device associated, lymph nodes, blood and other sterile sites in the body like your bones. These you will end up seeing in patients where you have had some kind of device which has been placed in, or patients who are severely immunocompromised like the ones who are with HIV/AIDS. The general symptoms are pretty vague. They could be anywhere from fever, weight loss, night sweats, decreased appetite, loss of energy or rashes. The pulmonary is usually similar to what you would get with tuberculosis. Extrapulmonary, we generally end up seeing them more with lymph nodes. That is especially true for children. And in adults, generally when we say an extrapulmonary, it's also because of the kind of operative procedure that the patient could have undergone, especially laparoscopic. So you can divide them roughly into two groups. One we call as rapid growers, the other is we call as slow growers. Typically the definition would be rapid grower is less than 7 days and slow grower is more than 7 days. But slow growing typically takes a little longer than that, longer than 7 days, so it's about 14 days odd. The rapid growing species that we are really concerned about is your abscessus, Chilone, Fortitium and Mucogenicum. And the slow growing ones are your MAC. These are the major ones. Kansasi is another one which is a major concern for us as well, but we generally don't pick them up too much in our community here, but that's one of the major concerns for a pulmonary disease. So coming to the diagnosis of a pulmonary NTM, you need to have a radiological as well as a microbiological diagnosis. This is from the clinics of infectious disease. So the clinical radiological diagnosis that you're looking at is evidence of pulmonary signs and symptoms along with the nodular or cavitatory opacities in the chest radiography or an HRCT. Microbiologically, you need to have two separate set of AFB positive, and your culture should be positive from one of the either the sputum or the bronchoalveolar lavage, or else you need to have a biopsy which shows the presence of an NTM. You need to have both the clinical diagnosis plus one of the microbiological diagnosis to call it as an NTM, proven NTM. The radiologically, the cavitatory disease in the upper zones are similar to your pulmonary tuberculosis. This is especially true for Mycobacterium canceraceae, and 50% of the other MACs can also cause similar kind of a feature. In xenopy, the lung infections are generally seen with cavities, but these cavities are thinner walled as compared to TB. Now these are only differentiating features. None of these will be able to just sacrosanct tell you that this is NTM versus tuberculosis. CT and an MRI is especially important when you are looking at either a lymph node based disease or a disease in the sinuses respectively. Lab plays a huge role. This is where the microbiologists are really required, because these are the ones who would give us a fair diagnosis. You may be thinking that it is an NTM, but to actually get a diagnosis, you need a microbiological support here. So the labs, when you are looking at a respiratory sample, it is important to tell the patient that you don't gargle your mouth before you give off the sample, because your water could be contaminated and then you could get a contaminant there. So we tell the patients to send in a fresh sample in the morning if possible, at least about 3 respiratory samples like we did in the first case, over an interval of a week. Don't send the samples on the same day. And if you get even 1 or 2 samples positive, 2 is what is the ideal, then you know that it is probably likely to be NTM or a tuberculosis, whichever of the 2 that you'll end up having. Gene expert is typically negative, so that's one of the ways that you could probably pick up. If your AFB is positive but gene X is negative, that may be one of the ways that you could know that it is likely to be an NTM. For a cavitatory NTM pulmonary disease, the sputum samples often is all that is required for diagnosis. The BAL and the bronchial cultures that you are looking at is only when you don't have any other option. Bronchoscopy is performed only in patients suspected of having the pulmonary disease and where you can't really look at an induced sample. And when you do a bronchoscopy, it's important that you don't introduce any contaminant there, because if you wash it with a tap water, again you could get the environmental contaminant into the bronchoscope. A smear positive and a Gene X negative result gives you a high suspicion of an NTM. For an extrapulmonary NTM, the body fluids, abscesses, tissue, aseptic collection is extremely important. So you need to see that you follow a strict asepsis, because it's an environmental bug. So you could cause a contamination and you may falsely call it as positive. Swabs, like in every other culture, is not really recommended, but it has some role if you're actually saturating the swab completely and sending it across with a good quality and quantity of the material. Specimen should be cultured ideally both with the liquid and the solid media. I will not be going much into the details of the microbiology here, but it suffices to say that you have many techniques in which you can now pick up like your whole genome sequencing. You can have DNA probes, you can have even multi-tops, which can be helpful in picking up patients of NTM from the lab samples that we have sent. And these are far better than the earlier techniques that we had, and gives us an easier way of picking up. Now, I'll be cutting short a lecture by a couple of slides. So, in the treatment front, what we need to realize is the slow-growing NTMs, you need to probably add a rifampicin to this particular regimen. So, the regimen generally comprises a macrolide, a combutol, a rifampicin, along with an injectable aminoglycoside. For the rapid growers, the crux is still a macrolide. Along with that, you could give aminoglycoside, fluoroquinolones, your linezolid, tigecycline, carbapenems and cephalosporins depending upon the sensitivity. So for the pulmonary, the major treatment protocols that you are looking at will be a rifampicin ethambutol along with a macrolide. You need to repeat the sputum cultures here, and once the cultures have come in negative, that is the time point that from there you continue the treatment for a period of another 12 months. So by and large, most of the treatment extends to a period of 1 year. In terms of abscesses, if you have an abscesses related lung disease, it's a difficult organism to treat. So here, if there is a possibility, then we should be looking at source clearance, source control. So there might be a need for actually undergoing some kind of a resection in that particular area of the lung to be able to control the infection. most of the patients with a bronchiectatic disease, you would be able to manage even with a 3 days a week dosing regimen of clarithromycin, ethambutol, rifampicin. But once wherein the disease is quite progressive, you would need to look at a daily regimen. Earlier, we used to look at giving an injectable for at least a period of first 1 or 2 months. Nowadays, we have reduced the need for an injectable because most of your trials and randomized control studies have shown that may not have a major role to play. So we do give injectable in certain individuals to shorten the duration of treatment, and you could give it for the first 1 to 6 weeks. We do not have amikacin liposomal inhalation and suspension in India, because that's one of the protocols that can be utilized in patients who have not tested negative despite appropriate treatment for a period of 6 months. Prophylaxis for NTM, we look at only in patients who are HIV positive, and these are typically given for patients with CD4 counts of less than 50. And azithromycin or a clarithromycin is the regimen that we really look at, and once they are immunocompetent and the CD4s are gotten better than 100, then we tend to stop them. So the take home is most patients with NTM are misdiagnosed and treated as tuberculosis, sometimes with a multi-drug resistant regimen, which results in actually a significant morbidity and mortality in the community. The diagnosis and treatment of NTM in resource limited setting is extremely challenging, and there's an urgent need for an increased suspicion, a better diagnostic facility that provide drug susceptibility testing and a newer evidence form guidelines to be really followed for our country. Thank you.